Thank you so much for coming to CanMed 2019 and spending your day here with us. Thank you for, even just showing up to this panel. It is not easy to show up anywhere at 2 p.m. on a Tuesday. Usually, you've got work, driving your kids around to soccer practice, picking them up from school, or, maybe you have to go to school and you're here instead, which is actually a very, very special thing. The fact that you are deciding to educate yourself about the power of the plant, which is pretty phenomenal. If these people definitely are proof of that, educating about the plant is the only way we're gonna tackle this industry, tackle this space, and do it right. Education is the only way. Before we go any further, I'm going to introduce myself. My name is Mary Carreon, and I am a journalist, and I've been covering the cannabis beat for about 5 years. And I'm currently the editor at Mary Jane, where we cover everything from culture and science, news, everything in the cannabis space. If you don't know us, you should look us up. You can find us at maryjane.com. So, as I was saying, education is the reason why we're here today. And we are at a pivotal moment in history where education is going to change everything. So, like I said, you guys are here today to become educated, and we are here to talk about how cannabis is going to be incorporated into the education system. And that is historic. Everyone who is here today is also making history. And the fact that we're able to sit here in this kind of ballroom experience is a very unique thing. We wouldn't be able to do this 20 years ago, or even less than that. Not too long ago, we were not able to do this, so this is a very, very big deal. Being here today is proof of how powerful lifting the chains of prohibition is, even if it's only a little bit. Look how much we're able to do. Look how much we're able to do with just a little bit of leeway. And imagine how that's going to be in 10, 15, 20 years. It's going to be a great thing. Another thing, us being here today, is proof that the government isn't always right. And the fact, not that we need any more examples of how the government isn't right, but it's proof that there's a need for education. It's a proof that there's a need to know about the plant and move forward to progress into what this whole industry is going to become. And I feel lucky to bring this kind of education through a stacked group of rock star panelists, and I would like to give them a round of applause. Like I said, they could be doing anything today, and they're here. They're here with us, so that's a really great thing. And thank you all for showing up today. This is a really great experience. You guys are just as much of rock stars for showing up and showing your love for the plant. So thanks for that. And before we get into our discussion, I'm going to briefly go over a PowerPoint just so everybody's on the same page and we know what we're discussing. So let's get into that. All right, so who is on this panel? We originally had some people on this panel, but we have new people on the panel. We have Caroline MacCallum, who is here. Tell us a little bit about yourself, Caroline.
Hi, everyone. Is this on?
Nope.
Can you hear me? Okay, sorry. I'll bring it a bit closer. Okay. Hi, everyone. I'm Caroline. I'm a physician. I have done my specialty training in internal medicine, and I focus on complex pain, and I do addiction and complex disease. I formerly, in my training, worked as a pharmacist, and so I bring a combination of skills, and I'm working out of Vancouver, BC in Canada, and obviously we've got some things that are a little bit different up there in terms of cannabis regulation. So I'm hoping today I'll be able to draw on a lot of those experiences and perhaps we can have a discussion about what opportunities may be possible in the US in the future.
Yeah, so having Caroline on our panel with us is a phenomenal thing because she's going to be able to provide some differences in terms of where the United States is currently and where the United States can be later, using Canada as a mirror in terms of education and the freedom that they have up there in terms of cannabis. And we also have Dr. David Bearman. In a minute, he went,
I hope I didn't get anybody with that bomb there. Wow.
Yeah. Tell us a little bit about yourself.
Okay, that inauspicious beginning. I'm a physician. I've been practicing medicine for over 50 years. Part of that has been doing addiction medicine. I've been doing cannabis medicine for 20 years, as well as pain management. In addition to being a clinician, about half my career has been as administrator at all levels of government. I am an author. I'm pushing my new book, Cannabis Medicine. I think it'd be a great textbook. It was written in combination with a nurse, specifically with the idea of it being a textbook. I also have other books on the history of drug laws and the way drugs have been used in society. And one of the things that's disturbing to me is how little physicians know about the endocannabinoid system. It's arguably the largest neurotransmitter system in the human brain, central to homeostasis, modulates the speed of neurotransmission, important in the functioning of the immune system, and it touches on an enormous spectrum of illnesses, and it is frankly criminal that so few medical schools actually discuss the endocannabinoid system, let alone talk about the medical utility of cannabis.
And that's very, very true. And now we also have Dr. Tom Folan, who is joining us today, and we're really grateful he's here.
Thanks, Mary.
Yeah, absolutely.
Hi, everyone. Welcome to CanMed. I'm excited to be here. This is my first year presenting on a panel. You will have the opportunity to hear me talk later about cannabis hyperemesis syndrome on the 5 o'clock panel. And I was asked kind of last minute to fill in for Daniele Piomelli, who couldn't be here. A little about myself. I'm a neuroradiologist by training. I graduated medical school in 2007, and through a personal story, one of my siblings became quite ill with an autoimmune disease, and ultimately cannabis proved instrumental in his rehabilitation and continues to until this day. As part of my second act in medicine, in addition to being a neuroradiologist, I maintain a clinical practice in cannabis / cannabinoid medicine. My focus is on glioblastoma patients. Given my neuroradiological training and interest in all things neurological, but I'm also educating myself and taking on clients with anything from autism to low-level anxiety to medication reconciliation in seniors, all things cannabis and endocannabinoid system. And just to echo what Dr. Bearman and Dr. MacCallum were saying, it is absolutely criminal that we have physicians graduating medical schools, as I did in 2007, not learning a single thing about one of the largest systems in our body.
Absolutely, and that brings us pretty much to our next point here, is the fact that the endocannabinoid system is one of the largest systems in our body and in our brains, and the fact that no doctors are being taught about this, I mean, that needs to change given how many people are using cannabis. And some startling statistics are the fact that only 13% of medical schools even mention the endocannabinoid system, according to a survey by Dr. David Allen, and only 9% of universities report teaching about medical marijuana, according to Washington University School of Medicine. And ultimately, only out of 172 medical schools in North America, of which 101 replied to a specific survey, 66% reported that they were not equipped to prescribe or even answer questions about medical marijuana. So 90% of doctors aren't learning anything about medical marijuana in school, and that's very alarming. That's a problem. That's a problem. It needs to get fixed, and that's why we're here today. So that's really wonderful. And so we'll go through this very quickly, you guys. But what is the endocannabinoid system? Just to get everybody up to speed, is basically a biological system composed of endocannabinoids in the body, which are neurotransmitters that bind to cannabinoid receptors through our vertebrae. Through our vertebrae and through the nervous system. They bind to CB1 and CB2 receptors. And it controls homeostasis. It impacts a healthy operating immune system and impacts our sleep health. So it really impacts a lot of things. And yeah. Okay, so I'll just leave this on the board for you guys for now. But these are the schools that are currently offering courses on cannabis. And these are not all of them, but these are some of them. And they are pretty major universities, but still not enough. So now we're going to get into some of these questions that I have. And for the first question I will ask is, for our wonderful panelists, how does the current federal status of cannabis impact the various forms of education that you are allowed to pursue? Please, Caroline.
Okay, I'll start. So coming from the Canadian experience, and from this angle, I was joking to Mary when we were just chatting earlier. I was like, what do you mean? Like, how does this impact? Basically, it hasn't affected my practice of cannabis over the past 5 years because we've recognized at a federal level a medical cannabis system. It has gone through multiple changes over the years, and now it's a lot easier for patients to get medical cannabis than it used to be. The access has evolved dramatically, and we now have over 170 companies growing medical cannabis. Sorry, they've been licensed, but in various stages of growing. And so for me, it's been really easy, honestly. However, with legalization for recreational purposes at a federal level, which occurred last fall in 2018, now we're seeing even greater need for education. So I don't really feel like I've had red tape in terms of my ability to educate, but just the need is just so much greater. And I think one of the big issues that I'm facing, or just the difficulties I'm having, is with redundancy. So unfortunately, we're not speaking to one another at the various levels. So there are federal groups, like federal programs, different provincial or state programs, different associations and stakeholders and universities, all creating very similar things. And it's really unfortunate because I just think we could combine and be stronger and get more experts involved instead of trying to do our own version kind of on our own instead of in a team. So I wouldn't really say there's any barriers to creating educational opportunities in Canada, but it's just been that we're not really working together as well as we could.
Yeah, and you guys have definitely a level of freedom that we don't have here. Mm-hmm. And that freedom, I'm sure that's extremely overwhelming.
It's too much.
It's more than the federal government. It's the 70-year history of stigma that's been attached to cannabis. Most people are unaware that in 1937, the AMA testified vigorously against the Marijuana Tax Act, and in that testimony said the AMA knows of no dangers from the medical use of cannabis. In terms of medical schools, most of them won't touch talking about cannabis with a 10-foot pole because many of them are reliant on federal funding and they have no idea what the federal government will do. So as the recent hubbub over whatever it was that Trump did do or didn't do, we can see that there's a lot of subtlety in terms of encouraging or discouraging people to do certain things. And medical schools are discouraged from even doing research about cannabis. Dr. Donald Abrams, who is an oncologist at UC San Francisco, for about 8 or 9 years submitted a proposal to NIDA to demonstrate whether or not cannabis was beneficial in treating the pain, neuropathic pain from AIDS. And finally, the director of NIDA said, Don, you have to submit a proposal showing the dangers of cannabis, not the benefits, because we're the National Institute of Drug Abuse, not the National Institute of Drug Use. Mm-hmm. So in listening to researchers talk about the difficulties that they've had, they've been enormous. And it's very difficult to even do research with whole cannabis. Much of the research that's been done is with isolates or with Marinol or with CBD alone. And as the folks in Nimbin, which has the longest drug war protestable, second longest after Seattle, they had a sign there saying the plant, the whole plant, and nothing but the plant. And I think that there's a great problem in the medical schools utilizing the plant, the whole plant, and nothing but the plant, and talking about the plant. They're much more likely to talk about the pharmaceuticalization of this plant, and I think that also represents a barrier in addition to the stigma and the money that the federal government wields.
So on that note, what is happening right now, currently, in terms of medical education? Dr. Folan. Sure. Yeah.
So I'll take this. So as Mary pointed out earlier, a 2017 study out of St. Louis University in Washington found that 9% of US medical schools out of the 101 that responded were actually teaching anything about the endocannabinoid system. And I believe another statistic there was 85% of students didn't feel comfortable discussing cannabis with their patients. So we have this really weird situation where we have 33 states which have legalized in the District of Columbia, and in many cases, I would say most everyone in this room knows more about their local doctor does about cannabis, which is just an unacceptable and an untenable situation. And as Dr. Bearman points out, a large part of this has nothing to do with the fact that there's nothing to teach about cannabis, or that the endocannabinoid system is not implicated in autism, in fibromyalgia, in migraines. It has to do with the stigma that cannabis is a drug, and just like how we all are aware that NIDA will not commission a study or approve it unless it is focused on the harms of cannabis. And we all heard from Dr. Sulak earlier today talking about a crutch versus a tonic, and these really important key concepts for cannabis. And it just becomes increasingly obvious every year that the status quo is unacceptable. But what does portend hope and give us room for hope is, as we see on the screen here, all of these colleges that 10 years ago would not have been teaching about cannabis or taking it seriously, the writing is on the wall. So I certainly think that 9% number is going to continue to increase. And one of the issues that is talked about with incorporating this into the medical school curriculum is, well, they say, well, where are we going to find the 10 to 20 hours of coursework? And no joke, this is an actual thing that's being discussed even with pharmacy schools who are also looking to incorporate cannabis education. What are they going to give up? So, that's just where the conversation is at. But certainly, as we said, given our increasing recognition of the ECS, its pleiotropicity, the many different targets, CB1, CB2, GPR55, TRPV, all of these receptors, again, there's just no way we're going backwards on this. So forward momentum.
So Caroline,
Can I
yes,
say one other
please.
thing, which is that the doctors out there recognize that they don't know. I've had more than 100 doctors in southern Santa Barbara County refer patients to me because they feel uncomfortable, not just because of their lack of knowledge, but because of the stigma that's associated with this. And I've tried to do CME, and we have done CME. We've got an organization called the American Academy of Cannabinoid Medicine. If anybody wants to collaborate with us or collaborate with the people from Canada, we need to have more of these kinds of conferences. And we need to integrate this into like pain management conferences, and I have seen some gradual improvement. So I think that we are making progress, but I'd like to see it be a lot more rapid because there's no excuse for the status quo.
Absolutely. And Caroline, what is your involvement in the education system, in the university system in Canada? And how is it there? How does it differ from what we're doing here?
Yeah, so I do educate on a number of different levels and with different groups of people. Yeah, I'm really close. Is this on? Sorry. Okay, I'm really close. Sorry. So at the university, currently, I teach a couple of lectures for the School of Pharmacy. So particularly, I'm working with they've got a pain curriculum, so I do a lecture there. I also lecture in their, with some fibromyalgia and other complex diseases in their curriculum. And in the medical school, actually, not at the undergraduate level, but at the postgraduate level, I actually take the fellows in my clinic. So I frequently get geriatric fellows, pain medicine fellows. I've had an orthopedic fellow, also palliative care. So these areas are obviously areas where we use quite a bit of medical cannabis, but I'm actually getting interest from pediatric fellows. So these are residents in their final years of training, which is really great. And so they come to the clinic. Sometimes they'll spend a few days, maybe up to a month with us, and really learning a lot about the plant. And so I think that that's been a really big win for us, that at the clinic where I work is actually considered a clinical teaching site by the university. We're recognized. I was surprised that it didn't take quite as much work as I expected. They were pretty open to it because, especially in Vancouver where I am, there's just so much cannabis use. That's really what we focus on, is that your patients are doing this anyway. So let's try to equip the physicians with the right information. So I would say those are largely the two areas I'm educating, but we really need to get it into the formal curriculum. So this would be the undergraduate program like Dr. Folan has already mentioned. But I am teaching some academic half days as well. So that's a 3-hour lecture block that I get for those specialties that I've mentioned. So certainly we are seeing some changes, and that's been, I think, really beneficial to show that this is, we're certainly seeing greater need, and actually the fellows are going to their program and demanding it. So I think that that's how it's got to go. I can't just tell them what they need, also having the students recognize it as well.
One of the things, we're talking about professional training here, but there's no reason why this shouldn't be taught in high school and in junior colleges. Why should we wait until people get to medical school or nursing school? I mean, we're talking about a very amazing substance that has this incredible broad array of applications, as evidenced by your talking about the different specialties that come and see you. And doctors are hungry for this kind of information. I had 3 physicians from Ohio that spent several days with me. I had a doctor from London that spent some time with me. And we need to set up more fellowships and more opportunity, not only for students to learn by the lecture method, but by working with doctors that are in the field. One of the things that I might mention is years ago I started a speakers bureau on sex education at the University of Washington, and the faculty, OBGYN faculty and psychiatry faculty said, look, the medical students are meeting once a month for 3 hours to talk about human sexuality. Don't you think we can have a few more hours in the curriculum? So I think that organizing the medical students to demand this, or even to self-educate themselves by inviting people like the people on the podium here, Dr. Piomelli or what have you, is one way to help move things forward. You also have to have people on the inside, like Dr. Piomelli and like Bob Solomon, who can lobby for having more time in the curriculum. And as has been pointed out here, there's a lot of competition for face time with medical students.
On that note, yeah, absolutely. What do you think we can do to get medical schools and universities to teach about cannabis? Like, is there anything that we can do, either students or as professors or doctors?
So I'll comment on that. I think it's already occurring right here in California. UC Irvine, UCSD, and UCLA have medical student associations focused on cannabis, cannabis as medicine. There's the cannabis initiatives that are famously occurring at UCLA with Ziva Cooper. And so this is generating excitement. And also by virtue of, CanMed occurring every year and all of these cannabis conferences, people are actually approaching us now. I get many emails and phone calls, texts like Dr. Folan, we think what you're doing is very exciting. I'm currently working at the State University of New York. I'm in discussions with them about potentially talking to their medical students about cannabis. So really just by virtue of being an advocate for the status quo, for the fact that patients are using this substance anyway, and really kind of just shaming the medical establishment into understanding that, look, there's 2 ways about this. Your patients are either going to use cannabis and you're going to know nothing about it, or your patients are going to use cannabis and you're going to know about it. And you'd be, with that tact, we actually are achieving progress where we're all around the country. I believe just recently this month in South Florida, one of the osteopathic schools there just incorporated the teaching of medical cannabis for the first time into their curriculum. I know Miami-Dade Community College just started incorporating some classes. So the change is occurring, but it's incumbent upon all of us to continue pushing for this change, to continue talking about that, as again, Dr. Sulak mentioned today, how cannabis, it changed my life. And the amount of times we hear this from patients is just overwhelming, in fact, and you almost believe like it's a canned report.
You mentioned patients, and I think that that's an important focus. In California, we're the Wild West, and a lot of physicians that are making recommendations for cannabis aren't really practicing medicine. They're just minting money. They're spending 10 minutes or 15 minutes with the patient, and fairly often, some of these patients come and see me and spend another hour with me because they don't understand how it works. Patients want to know how cannabis works. They want to know why it works. They want to know what it treats. They want to know what dose they should take. They want to know what to do if they get high. These are all things that people like those of us up here that have worked with patients over time have come to learn and come to understand through hard work, through listening to the patients. And there should be a more solid foundation for us to do this, rather than having to spend years of experience or digging into dusty books to find the answers that we're looking for. We really need to directly assault the stigma. Remember that the Marijuana Tax Act was passed for economic reasons, because DuPont and the petrochemical industry was concerned about competition from hemp. It had nothing to do with marijuana.
I think I'd be remiss not to mention, law schools as well. And so we're going to start to see even pharmacy schools and nursing schools and so forth, psychology and the works. But just to mention, we were both recently talking about medical legal cases, and certainly the need for physicians who are knowledgeable in cannabis for medical legal purposes. So certainly testifying, and I almost get a request every week for something of that nature, which is a huge amount of work to do, especially because you really do have to be able to go through all the evidence and to be able to support the case. So I have also been asked to speak for a lot of law societies, just as an evening event, but I think we're going to start to see that in their curriculum as well, for sure.
So how important do you think it is then that medical schools and law schools and, the various forms of schools, how important it is for them to work together?
Well, I suppose that the law schools, they already are trained in terms of dealing with substance issues. There's a standard textbook that was written by the former dean of the law school up at Santa Clara, Gerald Ullman, and just as what's your last name?
That's okay, MacCallum.
MacCallum, all right, I'll get it straight here. Just like Dr. MacCallum said, I have spoken to legal groups, usually groups of defense attorneys, and the interesting thing in regards to the cases that I've been involved in, there's a couple of interesting things. One is that you get exposed to things that you wouldn't get exposed to in the clinical practice of medicine. You get asked sort of unusual questions. But the other thing is how often the defendant is obviously not guilty of the offense. And I've written my reports in the hope of educating the district attorney to get them to either have a more reasonable plea deal or to drop the charges. And generally speaking, I haven't been that effective at educating the district attorneys through my reports, but I think it's critical for particularly prosecutors and law enforcement personnel to be familiar with this. Now, the other problem is that we are stuck in medicine with a lot of people who hold themselves out to be experts and are not. And I know the California Highway Patrol had such an expert. I won't mention the man's name, but he created his own research, which wasn't very well done, and that was then integrated into standard police policy. He was the guy who said, if you smoke marijuana, you get a green tongue. Can I have a show of hands of how many people have seen green tongue? Okay, I'm done.
Can I just add one more point
yes,
onto
of
that?
course, of course.
Because I think we could go all day. You just prompted me on a couple of other things. So I think what's really important when you ask, the medical schools and the law schools and how that could happen is that what I noticed, especially doing the 3 cases, I did one on impairment, one on anxiety, and one on pain specifically, was that I really couldn't give them an answer until I explained the science of the plant. They just want a one-pager, and it doesn't work that way. So in actual fact, I was really a glutton for punishment because the first case I wrote 60 pages and I included a dictionary of terms. I had the 10 clinical pearls that you need to understand what I'm even talking about. And then all 3 cases, I was actually doing a rebuttal of other physicians' opinions, which were completely wrong. They were psychiatrists, and so therefore, the person had anxiety, so cannabis must be inducing the anxiety, not that she's using cannabis to treat the anxiety. So really for law, for them to be able to, we each have to help each other because they don't even know the science.
Yeah, absolutely. Absolutely. It goes back to also what you were saying about there is no communication happening between the various groups of people who are either governing cannabis or teaching about cannabis, and there's redundancy as a result.
Yeah.
I just want to piggytail one point on that, which is that there's a lot of work going on right now with this toxicologist called Ryan Marino, where every day on Twitter he debunks these news stories where police went to a site and he picked up some fentanyl and he passed out and he overdosed. And we're even seeing these stories coming out about fentanyl-laced cannabis. Believe it or not, where it was talked about. And so it is incumbent and especially important for those of us within the medical community with knowledge of cannabis to be active on these forums and talking about the ridiculousness and non-possibility of these things. And also just to add on as well, in the current state, I practice in New York currently, and in New York, if you recommend medical cannabis, there's 4 hours of required CME. So in addition to the medical schools and teaching there, we also want to be teaching at the state levels that if you have a state cannabis program, how are those physicians getting educated at that point? So in California, there's no such requirement.
And in Canada, there's no requirements at all either to authorize cannabis, which is very different when you look at programs like Suboxone programs or methadone. You must have 10 hours or whatever number. And so really this issue of competencies and having standardized programs that actually meet the needs for the prescribers, I think are very important. So yeah, Tom, that's a great point.
Sorry, Caroline, just to Caroline's point, in the US we can't call ourselves prescribers because it's federally illegal to prescribe. We are merely the recommenders that cannabis may be beneficial for you.
So, yeah, the reason that we can recommend is that fortunately the Constitution does not say when you get your MD degree you lose your First Amendment right to free speech. So if somebody asks you, what do you think about cannabis as a medicine, you can say, I think it's great, I think it's awful, I have no idea. But the government cannot put a gag over your mouth. Now I forgot what the heck I was going to say. What were you talking about?
We were talking about prescribing, and actually in Canada it's called authorizing. I slipped there and I wasn't sure how you guys word it, but basically because cannabis doesn't have a DIN number, so a drug identification number, which prescriptions do, you can't prescribe it. So it's not a typical prescription pad you're using. It's called an authorization. And so again, speaking to Dr. Sulak this morning, that these single molecules, this is what a DIN and pharma is really going towards, is making a single chemical entity designed to work in a certain way on a certain receptor, which, does obviously work for a number of conditions, but for a number of the conditions we're seeing, you do need a bit of a shotgun approach, and we don't fully understand how the plant works, but that's okay because my patients have, 10 to 20 symptoms I'm managing, and, using 10 to 20 medications just doesn't make sense, and they've already tried them and they're not working. So, this idea of a drug and prescribing, even this kind of nomenclature we're speaking, cannabis is just in such a different category. It's a different medicine. It's really hard to relate to it as, how we've been doing with other prescriptions.
So there's a lot of...
I want to pick up on that because we have marginalized all plant-based medicine. And I call that the cult of modernism, which came about in the 1920s as we began to marginalize plant-based medicine and rely more on single entities. One other historical note is cannabis was in the United States Pharmacopoeia from 1854 until 1942, and it was available in every drugstore in the country. Matter of fact, at the turn of the 19th to 20th century, cannabis was the third most common ingredient in patent medicines and prescriptions after opium and alcohol. So and in the 1920s, American doctors wrote 2 to 3 million prescriptions a year that contained cannabis. In fact, my father was a pharmacist, and he was at the University of Minnesota School of Pharmacy in 1928, and one of their assignments was to make tincture cannabis. And he said, and we had to be very careful because the alcohol was illegal.
Ha. Wow. Wow. So there's a lot of education that happens between doctors and their patients, and do you guys mind going into that a little bit?
So something that I think is really important is this idea of knowledge translation. So we can speak about the evidence here and about studies and high-level discussions, but patients don't necessarily understand that language. And so it's how do we move this information, from that area into the general public. And I think something that I'm becoming a bit better versed in is opinion editorials. So I've been fortunate enough in Canada to get a couple published, and so really trying to tackle an area of controversy. So I've done one on psychosis in cannabis, as well as pediatrics in cannabis. So really going for the big areas of concern and saying, I recognize that there's issues, but hang on, let's actually talk about this in a logical fashion, and bringing some of the evidence into play that, I can make it such that they understand and not focusing on all the nitty gritties. So I think that patients, when they hear it from that kind of lens, that it lands a bit better. But certainly in our clinic, we spend 45 minutes with patients. Our counselors spend an incredible amount of time, and it's really challenging because clinics you've just mentioned, a lot of them may do it in a different way than we do it, and patients suffer when they don't get adequate information, and then they actually end up coming to us because they've taken too much cannabis because they weren't taught how to use it, and so then their gut reaction is, I'm never going to do that again. And it's really unfortunate because with some education, they could have a very different experience. So the patient education is just so key. And this even brings into play what Dustin was speaking about earlier, lower dosing, and you don't need to be high, and all those kind of controversy, well, not really controversy, but patients' concerns. They're the first thing they say when they come in our clinic. And we really can address them adequately with education.
Yeah, I completely agree. I mean, we're learning, this is a CanMed conference, but just even to look at psilocybin and what we're learning there, equally important as the use of psilocybin, and something Dustin again pointed out today, is setting. And the other key concept in cannabis, low and slow, all these things where famously we remember Maureen Dowd going to Colorado back in whenever she went and consuming 100 milligrams of THC and feeling like she was dying, and we don't recommend that. Okay, we're much on the order of 1 milligram, 2 milligrams if you're going to be starting with an edible and then waiting an hour. And as Caroline pointed out, when we do our initial intake with patients at Solace MD, which is my cannabis company, we'll spend an hour just giving them the lay of the land in terms of what are your receptors, what's your ECS, explaining the concept of bespoke medicine, explaining the concept that cannabis is not one thing, it's much more than the THC and CBD you may have heard about, and the CBD that's everywhere of questionable quality, and all these other concepts. But again, in the same way that setting are essential to psilocybin and therapeutic use, the same is true of cannabis, and using with intent and using the smallest amount possible to achieve your desired outcome.
One of the things I want to mention is that probably the most effective thing in getting physicians to recognize the medical value of cannabis is their patients asking them about it. And I think that one of the things that we need to do as healthcare professionals is to ask our professional schools why they're not teaching about the endocannabinoid system and about the medicinal use of cannabis. I remember seeing in a cover article in High Times in 1975, and it had a list of medical conditions that they said that cannabis was useful in treating. And to tell you the truth, I thought, well, that's interesting. That's a nice tactic in terms of legalizing the recreational use. And then shortly after that, I looked at these things more closely, and the more I looked at it, the more I realized that, yes, all of those conditions and more respond to the use of cannabis. And we are saddled with this stigma because the laws have been used to marginalize discriminated against groups. And that's not unique for cannabis. I mean, it goes back thousands of years to trying to marginalize the pagans, or trying to marginalize the midwives that were known to the Pope as witches. So dealing with the stigma is important, and what's really important is to do what the doctors up here have done, and that is to stand up and speak out. You don't have to be obnoxious, you don't have to be abrasive. What you need to do is extol the virtues of science. And we are in an anti-science era where 98% of scientists say there is global warming, and yet the President of the United States is selling plastic straws for $15 a piece.
Yeah, that leads me to a whole other question and point is what responsibilities do institutions have to help shape an equitable future in cannabis?
I'm an idealist, so I would say they have a great responsibility. One of the things that's being discussed, which of course may be a little controversial, is the whitewashing of the cannabis industry, and the fact that we have so many predominantly people of color and Latinos in prison for maybe selling a dime bag, and yet we have other enterprises that are predominantly male, predominantly white, doing very well in the nascent cannabis industry. So certainly, I think there's a role that we don't whitewash or forget the history, as Dr. Bearman has talked about, that had nothing to do with the health of people, or the safety of people, or the welfare of people. And so I would encourage, as I'm sure all of us are, to go against the grain, to continue asking the questions, to continue spreading unpopular truths, to get involved. And yeah, I don't give the institutions any slack. As we're learning about MIT recently that accepted money from a known pedophile, we certainly need to be keeping an eye on institutions and questioning where their money's coming from and questioning what their narratives are.
Let me say also that one of the problems that I think we need to fight with cannabis is the pharmaceuticalization of cannabis. Dr. MacCallum talked about the difficulty in treating the plant as though it were single molecule medication. Well, it's not. And we've only had single molecule medication since 1897. And people, well, we have had some breakthroughs. These pre-1897 plant-based medicines were effective for many things. And I think part of the problem, and I hope I'm not stepping on too many toes here, is we have people who have got their priorities reversed, where they're looking at making the money first and helping the people later. And frankly, I think you can do better for society, and actually better for your bottom line, if you put the patient first. And that's really what education of the medical schools and nursing schools is important, so that we can put the patient first.
Yeah, absolutely. So what do interested professors and institutions need to know before adding cannabis as an option for degrees or courses?
Well, one of the things that we should do is to lobby state legislators in medical legal states for them to pay for research about the endocannabinoid system. And this will have people in the medical school, that have a horse in the race. We also, as Dr. MacCallum pointed out, should require physicians who are making more than, say, a handful of recommendations to have 8 to 12 hours of continuing medical education. I know one of the questions that we talked about in preparing for, one of the most important things we need to do in order to get cannabis taught in medical schools the medical schools are very concerned about how their students do on the national boards. So we need to lobby the national boards to have a couple of questions on the endocannabinoid system on the national boards. And one other thing I want to say before I forget it, because one of the questions is, what can we do and what can you do? And it seems to me that one of the persons that has been hurt by this stigmatization is Dr. MacCallum. And I think that what we need to do is lobby for Dr. MacCallum to receive the Nobel Prize for Science and Medicine.
So just another point kind of on this same topic is also considering other institutions. So at,
Everybody give a round of applause to Professor Robert Solomon, who is at the UCI Center for the Study of Cannabis, who made it today, and it's a big deal that he's here.
Who is not walking in late, by the way.
No, nope, absolutely not. Wonderful. It is great to have you here. Thank you. Thank you. Yeah, so now that we have a clinical attorney present, we can open the discussion to the elements of law that play into incorporating cannabis into the education system.
Okay, I hope I heard the question right. It's in my position, it's very different than when we talk about education of cannabis at any different level, because I'm at a professional school and we care in very rough terms about how to learn to be a lawyer, passing the bar exam, and getting a job. And so I don't see cannabis law as being any different than, say, sports law or entertainment law. It's a specialized field where we have specialized knowledge. And I said to the dean a few years ago, after attending a conference, we really need a course in cannabis law because there are jobs out there and it is a specialized field. To which the dean said, great, you're right, find someone to teach it. And so thus I offered the first cannabis law course in the country at a law school. So why is it important? Well, for one thing, this is a highly regulated field, and highly regulated fields mean, among other things, full employment for lawyers. It is very hard to negotiate, not that that's a good thing, but it is very hard to negotiate this field without a lawyer. It's also true that we have very specialized tax law affecting, you still have to pay taxes if you have a sale of illegal, federally illegal drugs, and there's very complicated law. By the way, cannabis businesses paid $5.2 billion in taxes to the federal government 2 years ago probably, and most of that was, guess what, in cash. Imagine going to IRS with bags of cash. We also have highly complicated internet law which applies to cannabis. We have all kinds of rules affecting investors that are not in other areas. We have incredible problems of local control. So the Cannabis Board has held that although localities can prevent distribution and growing, they cannot prevent deliveries into municipalities. Guess what happened? 24 municipalities are currently in litigation against the state. So local control is a major, major issue. There's the whole question of federal preemption and what it means. Law students learn this right away. Then there's the problem of driving under the influence and what we mean by that and how we will measure that. And I have a whole list somewhere on a slide.
I've got it for you.
There's more. I could teach 2 courses on this, frankly. But large law firms are now getting into the cannabis business, and a lot of it is similar to real estate law, except there are particular wrinkles based on local law and local control. So it's a complicated area. It is a specialty. It's going to grow. It's inevitable.
Absolutely. Thank you for that. So Professor Solomon works with Dr. Piomelli at UCI Center for the Study of Cannabis, which is very exciting. And together they are tackling the cannabis space in a multidisciplinary fashion with the law school, the neuroscience program, and everything. And they're doing incredible work. In fact, their school that they are putting together might be, a model that other schools look to figure out just how to make it all happen. So that's also very, very exciting. And it's happening at UC Irvine in Orange County. That's crazy. It's a sign of the times. Oh my God.
Can I just say one quick thing?
Yes,
I
please.
gave a talk at the Exploratorium in San Francisco, and as I was leaving the subway, the BART, I could smell, not the subway, I'm from New York area, you can tell. I could smell cannabis in the air and hear the Grateful Dead, and my first thought was, we're not in Orange County anymore.
Yeah, that's great.
So I was talking to Mr. Solomon on the phone and started to get into some of the science, and you suggested, I'm taking a risk here because I'm going to say that I'm not sure that I agree, that you felt that defending or dealing with cannabis was similar to dealing with other drugs. And I think that the attorneys do need to understand the endocannabinoid system, need to understand that THC is fat soluble in order to do their job well. And maybe you have the same feeling and I misinterpreted what you said, but I think that some special additional education would be helpful to attorneys in defending cases involving cannabis.
Yeah, we don't disagree. And in fact, in my course, Daniele Piomelli presents 2 sessions on the science, and our plan is next fall to really divide the course equally. So the science is critical. My point was that the skills are the same in trying driving under the influence of alcohol as driving under the influence of any chemical, and the police aren't particularly concerned with what the chemical is. We've had several sessions with law enforcement, and what they are really concerned about is the field sobriety test. And the field sobriety test is, you've all seen this on TV. Can you walk a straight line? There is something funny that they say there. In fact, it is somewhat true, a joke I used to tell, that I would rather have someone stop at a green light than drive through a red light. And the police said that there actually is some truth to that. One of the tests that they give is turn your head back, close your eyes, and tell me when 30 seconds has elapsed. And people who are under the influence of alcohol will often go, okay, and it's like 5 seconds. And people who are under the influence of cannabis or something else suppressing their system will be back there, and after a minute the officer will say, how long has it been? And they go, oh gee, only 15 seconds. I thought, So the problem, however, according to tests, and I do want to say, to credit police, to my surprise, they're very sophisticated about this. They're incredibly sophisticated. They're really obviously getting good training on the medical side, but they don't care that much. But the real...
You've seen different...
Well, I'm talking to LA police, so it's LA, and Orange County. But to them, the difficult part is changing lanes. Changing lanes involves a lot of executive functions, and if you're under the influence of almost anything, that's where the problems occur.
You want to go next?
Yeah, I'd just like to make a comment on that. And while I agree with the general concept you're mentioning, under the influence, it doesn't really matter what the substance is. However, what my concern is if they start to do random checks, so somebody's driving appropriately, there's no signs of impairment, and then they're going to start looking for cannabis. It's like, well, if you're going to do that, then why don't you also check for morphine and for antihistamines and anti-nauseants and other medications that we absolutely know could cause impairment theoretically, but you also have to understand that a medical patient who uses that medicine every day has a very different situation going on, and this gets us into tolerance, this gets us into what's actually crossing the blood-brain barrier and how their executive function is. So they really need to be pulling over the right people and not just, okay, we're going to check everybody for cannabis because it's Thanksgiving weekend or something like that.
I am going to take issue now regarding the training of the Los Angeles Sheriff's Department, there's an expert witness named Nick Murrow, who's a retired LA County narcotics officer, and he helped put together the drug recognition exam, and said that it has no scientific basis. There's also a lot of criticism of the field sobriety test. Now, there is a new test coming out that seems to have some merit, and it's nicknamed Druid, D-R-U-I-D. And it's the thing about the police out there is they have a very low bar to go over. It's not the same as being in court, and this is what the chief of police of Ojai said at a panel that I was on. We don't have to prove that the person was driving under the influence beyond a reasonable doubt. We just need to have a suspicion. I don't know how strong the suspicion is, and that's a very low bar. And then you start looking at the police report at the driving. In some instances, there is no description of the person's driving. All you have is that the person failed the field sobriety test, or in the case I'm working on now, they actually passed the field sobriety test, and they take a toxicology screen, and of course, the DA didn't go to medical school. He doesn't know how to interpret a toxicology screen. He probably doesn't know that the cannabinoids are fat soluble. And you end up with a problem, and this is not a problem just with cannabis, but to a hammer, everything is a nail. To a police officer, everything is a crime. So if you have a stroke, if you have a hypoglycemic episode, if you previously had a traumatic brain injury, and now the police officer stops you, they are likely to think that you're under the influence of a drug. And if you're a regular user of cannabis, which you might well be, they're going to draw your blood. Now, I think one of the best defenses is to ask for serial draws of your blood so that you can see that the THC is coming from the adipose tissue and not from the result of having recently smoked a joint.
Wow, that's very interesting.
Yeah, that's a great point. I was going to mention the same thing, like being fatigued. You know, there's rules for how long you can't drive. Well, you can only drive for so many hours. It's no different. There are medical conditions that can cause impairment. And actually, my pain patients say that they are better drivers when they use some amount of cannabis. I'm not saying use cannabis and drive, but I think you need to look at the full picture and really understand what's going on and not have people in court acting as scientists and doing all this. They can really make misleading cause and effect and associations and draw these conclusions that may not be there.
So I have to wrap up here very quickly, but one issue that I have to ask in terms of education across law, education across medical, and in the United States and in Canada, how do you go about educating about pesticides and pesticides in products and pesticide use among growing? And also, because patients consume them.
Well, I don't think until the U.S. has federal, legalization, you're going to be able to get anywhere with these issues that are very much all across the board apply to all states. It's not just, able to have an individual state rules on these sorts of things. Then you need to have mandatory lab testing, more than just pesticides now with vape, vitamin E, esters or acetates, and all these different derivatives that can also potentially have long-term outcomes we don't know. So needing to get funding for levels for research. So we have CIHR in Canada, and you don't have to study abuse. You can study other parts of cannabis, which is really important, not to just be focusing on harm, moving into looking at CBD, looking at other things, and not just recreational use, looking at medical. So I think that, it's gonna be difficult unless you're united on these issues in terms of how you're gonna go about getting answers.
Yeah, I'm in complete agreement with Caroline, and in fact, if any of you who follow me on Twitter will, have noted that I was recently arguing with the Surgeon General about this very point. So where he was saying, these kids are dying from vaping, the marijuana cigarettes, and the whole thing, and we're like, well, actually, you're just making the argument for federal descheduling, for research, and for regulating these products, so that we're not producing 5,000 of these vape cartridges per week, as was occurring in the state of Wisconsin, which Wouldn't you know it, they don't have medical cannabis. So it turns out that people are resorting to these illicit products because they don't have access to tested, regulated products, and it's way beyond pesticides. We have bioaccumulation potentially from solvents, butane hash oil, so that's fine. You use a vape pen with, or whatever product with BHO, one time it's no problem. What if you're using that product every day for years at a time and you have this bioaccumulation occurring? So really the way forward is descheduling, research, regulation, and testing.
When you take a look at the newspaper articles, they are there to sell newspapers. They are not there to educate people, and they often don't read the research. They may read the press release about the research, and there tends to be sensationalization. People have been vaporizing cannabis for thousands of years. I mean, they found things where it was used in religious services as an incense. And so we've had the Stork Bickle volcano that's been around for 25, 30, 40 years. That uses the whole cannabis. And part of our problem in this country is we really don't regulate industrial production of just about anything that's dangerous as strongly as it should be. I mean, one of the things that I tell people who are questionable about cannabis, I said, it's too bad that we don't have these same questions about all of the other pharmaceuticals that are on the market. I'd like to see those questioned with the same intensity that we have cannabis, because I would feel a lot safer as a patient.
By best estimates, we grow in California about $3 billion a year worth of cannabis. We sell legally about $1 billion a year in cannabis. I was in Berkeley this weekend and talking to someone, and he was telling me about his cousin has a great business where he grows and he delivers to someone who drives to Connecticut. And I said, you realize that's not a legal business. And he said, no, I didn't realize that. I thought he was a legal grower. Well, our other $2 billion is going somewhere. And to make it worse, within the state, we have created all kinds of incentives to get a license to sell and all kinds of disincentives to get a license to grow. So there really are incentives, starting with tax, where there is a reason, as long as you can market your product, to not market it legally. And since the law requires a seed to sale, being able to track it, it's only the legal sales that are being tracked that way. So we are in a transitional period. Everything I've said is not me giving a radical opinion. Everyone knows this is the case. And so we need to start working this out, and we're still early in transitional systems. But somehow we're going to have to figure out how to have a more equalized distribution system, and that is going to be based on having a federal policy that, in legal terms, doesn't entirely suck, because the current policy is totally insane. It makes absolutely no sense. It's based on racism. It's based on trying to suppress groups of people. It's based on putting people in jail. And it's based on the just say no policy. Well, once you say just say no, you're saying abstinence is the only thing that makes sense. And that makes about as little sense in cannabis control as it does in birth control.
Wow.
One of the things I'd like to mention that reminded me of is the stigma extends to the highest levels. You may recall that former Vice President Biden's son died of cancer, and they did not use cannabis to try to treat his cancer, and he set up this program to take a look at options. And so I sent him a letter and said, you might want to take a look at cannabis. It wasn't, outrageous or anything. And I didn't even get the courtesy of a response. And you really have to wonder, here's a man who lost his son to cancer and refuses to even respond or have his staff respond to a suggestion that they look into something that we have known since 1974 can kill cancer cells. And as Don Abrams has said, there's more than enough basic science research and anecdotal reports to justify doing double-blind studies. And it seems to me when we're talking about teaching medical students and nursing students, pharmacy students about the endocannabinoid system, one of the hooks to hang our hat on is the fact that we can say for a fact that cannabis will cure your mouse's cancer. But we can't say whether it'll cure your cancer as a human being because the double-blind studies have not been done except for one in England on glioblastoma, which had some optimistic findings.
That's about all the time we have for today. We could talk about this forever. Thank you guys so much for showing up. Thank you for being here.